Let's say you have a 74-year-old patient who complains of memory loss. Step 1. Let's start with the basics. Remember the strategies of a good old-fashioned differential diagnosis when the patient is complaining of memory loss? Delirium could be the most acutely dangerous diagnosis you don't want to miss. And dementia is the worst diagnosis for your patient. Step 2. Let's think over the diseases that you're looking for. Delirium presents with an abrupt onset, a fluctuating course, and is a significant change in attention and other cognitive abilities. It also may be functionally limiting. Dementia, on the other hand, has a gradual onset and a plodding course. There is significant change in memory and one other area, and it is functionally limiting. Step 3. Let's go over some of the patient's risk factors. We want to look at age, gender, family history, cerebrovascular risk factors, HTN, CVAs, tobacco use, a sedentary lifestyle, an AFib. We also look at things like sleep apnea, or a history of depression or anxiety, or a history of delirium after surgery. Step 4. We need to ask the patient, is this memory loss a change for you? If the answer is yes, the next question for the patient, is it a minor or major change? Has this change come on slowly or suddenly? If the patient says that it's a major change that has come on quickly, you're going to need to do an evaluation for acute changes such as stroke or delirium. If the patient says that the major change has come on slowly, this brings us to a higher risk for dementia and will require cognitive testing or a referral. The next question we'll ask our patient is, has anyone else said anything to you about your memory? A family member perhaps? Or if applicable, has a coworker said anything? Corroborating history is really helpful with this complaint. No matter if they say yes or no, it's really about others having commented about the memory loss. So consider sending them home with an 88 form. We'll cover this more in detail in our upcoming video. And you can also do cognitive testing and consider a referral. The next thing we're going to ask our patient is, tell me, what sorts of things do you forget? Things like names, appointments, medications, paying bills. Names and appointments are really common mistakes, so ask if it's a change and it's creating problems or it's just a nuisance. Medications and errors paying bills can be an early indicator of executive function deficits. If your patient says yes, this is a major change, or they have early indicators of executive function deficits, they will require cognitive testing or a referral. The next question for our patient is, have you noticed any changes in your emotions, such as being more depressed or more anxious? If the answer is yes to either one of these questions, it requires cognitive testing or a referral. Finally, remember, to diagnose dementia, you are looking for patients with significant change in cognitive ability over time that has impacted their ability to function. Since some patients may come to you early in the course of a dementia illness, they may sense change in their ability even before it makes them dysfunctional. Remember, the earlier we identify patients, the better.